I'm going to talk about, I'm the one of the two neuropsychologists in our epilepsy center, and I'm going to talk about neuropsychology and epilepsy. So about the neuropsychological evaluation when we use it, and then, there'll be time for questions. Many people have questions, particularly parents, but also, adults who have issues with, for example, work-related, cognitive issues that affect their work or their lives. So I'll just start off here by giving some definitions. Let me share my screen first. Okay, so the title is Neuropsychological Evaluation in Epilepsy, What, How, and Why. So I'll just start with some definitions, and I think a lot of times there's just some confusion about what really this evaluation is and how we do it, and what the results mean. So I'm just going to start off with definition basically of neuropsychology in general, which is the study of brain behavior relationships. And in this case, behavior. So a neuropsychological evaluation, if you have any experience with it, is really the primary objective is to assess cognition, but there's a lot of other details that we're going to talk about. Cognition, though, we can't measure directly. We can only infer it from a person's behavior. So neuropsychology is the study of.
Well, it shows that parents are really wanting to know.
Sorry about that. So you have to infer from somebody's behavior, and so we talk about neuropsychology as the study of those relationships, brain behavior relationships. But the major question the neuropsychologist is interested in being, how does the brain mediate our behavior? And how does that happen in epilepsy, in different versions of epilepsy? Clinical neuropsychology is a specialty within professional psychology, so these are licensed psychologists, and the specialty is dedicated to enhancing the understanding of brain behavior relationships and then to the application of this understanding to such human problems like epilepsy, brain tumors, anything really that affects the brain. That's kind of the neuro part in neuropsychology. Refers to the brain, and that's really the focus of clinical psychologists who become neuropsychologists. Let's see. I am not moving. Why is that? Okay. Go here. Okay. So a clinical neuropsychologist has all the training that a licensed clinical psychologist does. In psychology, just I'm sure you've heard about what that is, but the definition that people talk about is the study of mind and behavior, and the study of those things in terms of how to assess them, to determine if there are problems, and then how to intervene. So if there are problems, what do we do about those? So that's what a licensed clinical psychologist does. A neuropsychologist is a licensed clinical psychologist who has additional training and experience in the neuro part. So neuroscience, brain development, brain anatomy, neurological and other conditions affecting the central nervous system. And by the way, the central nervous system is the brain and the spinal cord together. A licensed clinical, so the clinical neuropsychologist applies principles of assessment from psychology as it relates to CNS functioning. So the question really is, when you're assessing somebody with a neuropsychological evaluation, is their brain functioning normally? Okay, so the actual evaluation itself. So historically, neuropsychology was used to localize brain damage. It's a pretty young discipline, but so I'd say mid 1900s is when it really kind of came into its own, and a lot of those evaluations were aimed at helping people, for example, who have stroke in a certain area of the brain. We couldn't see at that time, imaging was nothing like it is today, and so we couldn't exactly know where some of these problems were coming from in the brain, and so neuropsychology was actually used to do that. Brain injured soldiers from World War II, for example, who had injuries to their brains, open injuries sometimes, closed injuries, what the consequences of that were, and where do we think that those injuries actually were in the brain. So localizing brain damage was the original intent, but then we had all of this, which John just showed us part of, explosion in neuroimaging, really, which allows us with a lot of precision to find where the problem is. So neuropsychology was no longer needed to do that. But what it continues to do, what we continue to use it for is to determine function. So the function of the brain, because you can't tell that from imaging. You can certainly tell whether there's metabolism occurring in certain parts of the brain or not. You can tell function that way. You can use functional imaging, for example, to look at what area in the brain might be responsible for helping us speak or remember things. So we can find that out from imaging, but we can't really tell the level of function or what that means really for a person's life. So that's where neuropsychology comes in. So nowadays we use it to help localize if we need to, but usually to characterize brain damage or dysfunction. So I say brain dysfunction because sometimes we have folks that we evaluate who have totally normal looking brains, and they have a lot of difficulty. And you can see this in some forms of epilepsy. For example, the idiopathic forms of epilepsy, where you have normal MRI, but the child or the adult has a lot of trouble in life with day-to-day functioning, thinking, problem solving, things like that. So we use neuropsychology evaluations to make diagnoses. That's a big function. We also use it to make treatment recommendations. So what we have is, we'll go a little bit more into this. We use different measures. So we measure cognition. We use different tests, and we look at function across a bunch of different domains. So we use tests of attention, tests of memory, and I have a slide that goes through some of those domains where you can see more of that. So we use tests in these different domains to look at a kind of a profile, and that can help us make recommendations for treatment. It can also help us assess when treatment has been helpful or not. And then also one of the things that neuropsychology is often used for in a tertiary care center for epilepsy is looking at change over time. So for example, if there's an intervention like surgery, trying to assess what happens with brain function when you take a part of the brain out. So for example, my two main roles as an epilepsy neuropsychologist at UCSF are, so the two basically largest populations that I see are children who have a severe form of epilepsy called electrical status epilepticus of sleep. And this is something where there's abnormal activity at night. And with this kind of epilepsy, there's a very high risk of development kind of leveling out or plateauing, or even regressing in some situations. So we see children with epilepsy with ESES to try to help determine whether any of that plateauing or regression has occurred, because that would indicate that maybe more aggressive treatment is in order. So it helps the physician determine how to change treatment going forward, and then to see if the treatment works. Okay. And then the other main kind of area where I work is in surgery. We have a surgery program, and the idea is to use neuropsychology to predict change over time. So for example, if you're going to have a surgery and have a part of the brain taken out, we want to try to predict what that might mean for your function. So depending on the kind of epilepsy, there is more or less literature that we use. And there we can actually even come up with numbers for certain kinds of epilepsy in terms of what the risk is of taking this part of the brain out for things, for example, like learning and memory, language, some of those really important things for functioning. Spatial skills are important, but they aren't, for example, but they aren't as critical for our day-to-day living. So we focus on things like I said, language, attention, memory, problem solving, things like that. So we want to try to predict to help counsel about what patients about what might happen with the surgery. And then after the surgery is done, to determine whether there has been any change over time. And if there has been, hopefully it's in a positive direction. If there is some change that is problematic, then we talk about what kinds of therapies that person might want to pursue to try to help with those issues. Any questions so far? Anybody about any of this? Okay. So the assessment itself, so we talked about before in the definition of what is a neuropsychological evaluation, about performance-based assessment tools. So this really means that what we're using are tests where we ask the person to do something. So the examinee to do something. That can be, memorizing a list of words, like a shopping list, or drawing a figure, and then remembering how to draw that figure later and drawing it again, for example. So something we ask them to do something. Usually it's paper and pencil, pictures, sometimes a computer we use. And these types of things fall in a number of different domains. So things like general intellect or general cognitive ability, to kind of help us get a sense of kind of where is this person generally speaking, and then that helps us compare other functions such as attention, language, some of these other things, helps us determine whether those functions are better or not quite as good as we would like, based on where sort of the general level of ability is. So that's this. And then there are a number of different other domains that look at specific aspects of thinking. So one is executive functioning, which I think a lot of people have heard of. Essentially, those are higher level skills that we need as we become adults. So like, for example, if you think of when you change from elementary school to middle school when you're a kid, a lot of executive functioning is required in that transition, because you now you have multiple teachers, you have multiple classes, sometimes you have lockers, and you have to remember to bring, your the right homework assignments for the right class, and be in the right place at the right time, on time. So there's a lot that changes, for example, when kids go to middle school and then high school. And a lot of that is related to executive functioning. And there's just a heavily increased, a very much increased demand for those skills as adolescence occurs in young adulthood. And if you've heard about our brains not developing until we're in our mid-20s, so that's kind of a more recent idea that people talk about. That's largely related to executive functioning, because these skills take the longest to develop, and so they develop into our mid-20s, which is why we might one day rethink the age of 18 as the start of adulthood, because these skills really are really important for adulthood. And really aren't finished developing until the early to mid-20s. We also look at other things like attention, attention being important as a kind of precursor for executive functioning. So if you can't attend or you can't inhibit yourself, then these other higher level things like planning something out, organizing information, or organizing a problem-solving approach, for example. You can't do a lot of those things without being able to attend and to sustain your concentration over time. So we look at attention, we look at learning and memory. Learning and memory particularly is important in things like temporal lobe epilepsy, which is the most common form of epilepsy. It's the temporal lobe right here. of the brain. And so we look at the ability to initially acquire information. So does the person need repetition? Can they learn something with just one trial, or do they need, for example, multiple learning trials in order to acquire the information? And then can they retain that information over time in their memory? Can they remember something later? And then do they need help with that process later? So do they have trouble maybe retrieving the information from their memory, or have they really just forgotten it? So there are a number of different things that we look at like that to help us understand how the person's brain is working. Language, so the communication, speaking, expressing oneself in writing and also orally, and then understanding both of those things, understanding written and oral communications. Visuospatial skills, so like navigating, knowing where your body is in space, so not misjudging space, for example, or having trouble like even navigating, for example, sometimes we see examinees who have trouble even just navigating in the clinic. So back and forth to the bathroom, can't remember which direction to go, getting lost in a mall, things like that. And then motor coordination. So we look at mostly fine motor skills in service of writing. So we're interested a lot of times in graphomotor ability, because that's what's important for example, children at school to write homework assignments and take notes. And obviously adults typing, writing in a work-related environment or any place else. And then sometimes we have measures of achievement, academic achievement. So the level of ability, we're looking at the level of ability across reading, math, reading comprehension, spelling, things like that. We tend to use this more with children, but also if we have a question about whether this person, maybe this person is, the examinee is considering a job in a particular area. And there are certain, prerequisite skills for reading and math and things like that. And so that helps, these measures help us determine information that can help with those decisions. And these things that we measure, we can, generally speaking, ascribe them to specific areas of the brain, or nowadays we talk about networks. So which network is involved in, like, for example, executive functioning has heavy emphasis on the frontal lobe, but also networks that connect to like subcortical regions and the parietal lobes up here. So there are different areas, and then also, like I said, networks that we invoke when we're thinking about these different functions. Okay, any questions about that? So just in terms of, I mentioned that we assess these different domains and we look for a pattern across these different domains. And so an example of that would be, for example, someone with temporal lobe epilepsy, again, the most common form, who might have memory problems, which is the most common kind of complaint with that kind of epilepsy. So in that case, we might look for a pattern that shows, relatively typical function and executive functioning, attention, language, spatial skills, some of these other things, but learning and memory being low or lower than we might expect. And so that would be a profile that would be consistent with somebody who has temporal lobe epilepsy, because memory is often the primary problem. So that's an oversimplified explanation of how we do these, how we look at these things, but you can get the idea. Okay, and then when we do the actual evaluation, like I said, we ask people to do different things. And so just to give you kind of an idea about some of the things that you might be asked to do if you had a neuropsychological evaluation. So for example, attention, you might be asked to repeat back a series of numbers or letters, which requires focus, like immediate kind of focus to a certain amount of information in order to repeat those things back. Or sometimes you're asked to repeat back a series of numbers in backwards order. So you've got to maintain that in mind and manipulate that information. That requires a lot of attention. For language, we might ask you to rapidly generate as many words as you can that belong to different categories. And our brain actually represents different categories in certain areas. For example, in the temporal lobe, we have different parts of the temporal lobe of the brain that are important for example, faces or objects, or they're not only specialized for those things, but they're critical to those abilities. So we look at those kinds of things with language, naming, for example, which is a big problem often for folks who have temporal lobe epilepsy, for example. For visual spatial skills, we might ask you to recreate, like using blocks. If we give you a model that has the blocks put together in a certain way, we ask you to reconstruct that. To look at your ability to process the parts of things and the wholes, and then how everything fits together. And then learning and memory, like I said before, sort of basic, learning and remembering things like a shopping list or a story. So how much we look at how much information you get in, and then after a period of time, usually about 30 minutes, we ask you to recall the information, and then we also do other kinds of assessment of memory after that. So for example, we might get then a recognition list. So if you have trouble independently recalling, say, the word list after 30 minutes, it might be that you forgot it, or it might be that it's hard to find it in your memory, to retrieve it. And so we might give a recognition list that kind of decreases the demands on the retrieving of the information. You just have to recognize it. So like the idea of a multiple choice test in school, it's kind of like that. So you don't actually have to produce the information, you just have to recognize it, which is easier. So we have some manipulations like that help us understand more about learning and memory. And this is just some information about who benefits most from neuropsychological evaluations. And a lot of this is based on just the tests that we use, and there are limitations. They're very useful, and there's a lot of flexibility with what we do, but there are some limitations for our measures. So the person who's going to be examined needs to have some expressive language, some ability to communicate, and follow basic, not necessarily familiar instructions. So sometimes people can follow instructions at home, like familiar things like activities of daily living, brushing teeth, getting ready, but not necessarily things that they haven't heard or they haven't been used to following or doing. And so those folks have we have a more difficult time really getting a good assessment of folks in that category. The examiner needs to be able to tend to a task for at least a few minutes at a time. And engage with the examiner in a meaningful way. So be able to, follow directives and respond and indicate one's preference or one's decision, and has to be able to contemplate information. So I see this a lot with younger kids who just don't have the abstract thinking or the ability to really think about what you're asking, to really jog their memory or retrace their steps, or things like that. What's in front of them is what they're thinking about. So if they can't go beyond that, then we often just won't be able to get as much information as we would like from that evaluation. And let's see, one more slides here. Okay, so part of the strength of a neuropsychological evaluation is neuropsychologists are trained in psychometrics, which is essentially the science of measuring things, in particular for psychologists' behavior. So there's a lot that goes into determining which measures to use and how to use them. So this is very different than what you might see in, for example, behavioral neurology, where you might do just a bedside exam. Here are 3 words, and then 5 or 10 minutes later, tell me those 3 words. You're not comparing those, the performance with any other people. So in neuropsychology, so what I'm talking about is this normative comparison idea, basically where we have normative information from other folks who are similar to the person who's being examined. And then that helps us determine whether the examinee is performing where they are expected to be for example, for their age. That's the most common thing we look at. So, so for example, if I have a 10-year-old child that I'm examining, I'm using normative data from other 10-year-old children, sometimes of the same gender. It depends on what the measure involves. But so the big question is your examinee performing like is expected based on their age or their gender or their education, or is it lower or higher? And so that's how we determine kind of level of ability across these different domains, is with these comparison groups. And one thing I would say about having this evaluation done, when you have, let's see, more complex epilepsies and situations, it's helpful to have an epilepsy specialist. So I'm, for example, a neuropsychologist who specializes in epilepsy. I see the lifespan, but I only see folks with epilepsy. And the reason for that is, so when we were talking about the normative comparison, epilepsy specialists have knowledge of like, for example, different normative data. So we have normative data at UCSF from a number of children who also have epilepsy, but for example, haven't had surgery. So that's the perfect comparison group for a child who I might see who's going to have surgery or has had surgery. Because the children who they're being compared to also have epilepsy, and epilepsy entails, and there's a lot of variability from day to day in functioning. So it's important to have your comparison group be as close to your examinee, the person you're evaluating, as possible. And so those are some of the special things that if you if you're talking about surgery or things that are higher risk or more complex, it's helpful to have the evaluation done at an epilepsy center. And these are just a couple of the things, some of the things for children and adults that uses of neuropsychological evaluation. So if for children, if there are concerns regarding development, if there are questions of, is this seizure or the brain, or is this medication? Because we know that medications have some cognitive and behavioral side effects sometimes. Also, when there are concerns about education or planning, or planning remediation. So for example, a child who has dyslexia, what should we do about that? The behavior plans and interventions for behavior also. And last slide. For adults, so similar things, seizures or the brain, or is it medication? What's causing the problem? If someone has taken time off work, can they return to their same job after they've had, say, a bout of status epilepticus or a lot of seizures and are on a lot of medications? Also things like disability, determining whether somebody qualifies for disability. A lot of times you need a cognitive or neuropsychological evaluation for that. So there's a lot of uses, and I'm over time. If there are any quick questions, I can answer them now. Otherwise, I think, turn this over to, is it Adam speaking next? I don't know. Any questions? Okay, I think we are.
Brianna, I just see one question in the comments that says, how often should a child get an evaluation?
Good question. I would say if there aren't really significant concerns that in terms of so why you're wanting your child to be evaluated, so or if there aren't if a surgery isn't involved, or the sort of standard epilepsy treated with medication, I would say the best times are around times of transition. So that would be going into school initially. Usually a child gets an evaluation at that time around 3 years of age when they go into the school system. But the transition points after that would be around 3rd or 4th grade. So that's when children move from kind of being taught and learning the basic skills, basic academic skills, to having to apply them. So more emphasis on reading comprehension, things like that. That's around 3rd or 4th grade. So I would have an assessment at that point. And then it's helpful, I think, before the child goes to middle school and then before the child goes to high school. Those would be good times. If otherwise, if there is a reason to evaluate more frequently, usually around 18 to 24 months is a good rule of thumb. if you do it more frequently than that, then you run into problems with practice effects and other statistical problems with administering the test so closely in time.